thank you so much. Thank you for having me. It's one of my favorite topics, is thinking about both productivity and healthcare, and so this is like everything I love altogether. As John mentioned, Paul mentioned, the background to this is that the ACA lowered the statutory updates for most non-physician providers. It used to be that the official update was changes in input costs. They didn't actually always do that, but that was at least what was in legislation. And then the ACA said, no, we're not. You should be able to get productivity growth, and if you can get productivity growth, then we can pay you less, and you should be able to produce the same amount that you were producing last year. So the idea kind of behind it was, this is the payment rate that should allow you to give a constant level of services, right? So when you think about things like Social Security, you might say, we want to find the right inflation index so that the constant level of benefits for people over time. This is kind of doing the same thing for healthcare. Now, because measured productivity growth in the hospital sector is extremely low, there were widespread concerns that this payment would be increasingly insufficient over time, right? So this is something that it's not, if the productivity isn't as high as economy-wide productivity, then it's not enough to keep up with costs, and it's cumulative. Every year, it's not enough, and it gets to be quite large over time. So that sparked a whole debate about hospital productivity and how to think about it. So as John said, I think there's huge mismeasurement in many aspects of the economy. So he talked about a project we have at the Hudson Center, which is looking at mismeasurement and productivity across multiple aspects, one of them being healthcare, where I think most people think the mismeasurement probably is the greatest. And so what John did was he calculated the change in cost per successful outcome after adjusting for case severity. And when you do that, productivity growth is much higher. Right? So that's the first thing you might think about doing as well. Instead of saying I care about healthcare, what I really care about successful outcomes. So if I'm going to define that as the good that I'm buying, then I can look at the price of that good and see what's happened to that over time. And so prices and productivity kind of go together. If the price of that is coming down, it's because the health system is able to produce the same thing for less, and therefore productivity growth has increased. Okay. And so it's John's work. He's done a lot of stuff. He just presented some of it today. It's a really important contribution to understanding hospital productivity. It's the kind of stuff that we have to do a lot of. He's involved in our project, so this is a nice area that works for both of us. So I think, though, he said I didn't agree with him, but I actually think that his measure likely understates what I would call the true productivity growth. Because what productivity growth should be is when the economy can produce something that it couldn't produce before. It's, as John showed you in the picture, it's an expansion of that possibilities frontier of what you can have. Okay? And it's possible that you can actually be better off and the economy can produce things it couldn't produce before, even while John's measure of productivity will show that productivity has declined. And so here's an example. So imagine in the first year, a treatment has a 20% probability of success and it costs $5,000. So how much is cost per successful outcome? Well, it's $25,000 per successful outcome. You only get 1 out of 5. In the second year, the new treatment has a 50% probability of success. It costs $15,000. The cost per successful outcome is $30,000. It went up. So that looks like a bad thing, right? But let's say the successful outcome meant you had an extra year of life. So between year 1 and year 2, you get an additional 0.3 years of life for an additional cost of, I made a mistake here, $5,000. I'm so sorry. So if the year of life, let's say it were $10,000, it's not. If the year of life were worth it, that 33, if it was $10,000, it would $10,000 over 0.3, then the healthcare would be more valuable in the second year than the first, even though the cost per case has gone up. And the idea being, in most things, if you tell me what the cost of a car is, I can buy as many cars as I want at that cost. Right? So if the cost of a car is $20,000, then I can buy 10 cars if I want, right? But if the cost per additional year of life is $10,000, I can't buy as many of those as I want, right? I can't buy 100 years of life at that cost. And so what happens sometimes is the technology allows you to have something that you couldn't have. And even if the price of that is higher, in other words, now I can have a second car not for $10,000, but for $15,000. But if I couldn't have it last time, and now I still want it, then you're better off, right? So it's a different way of thinking about what productivity looks like and what a deflator might look like. Here's an example of work comparing different ways of looking at it. And this is from Abe Dowda, Dunn, and Hall, and they sort of compare two different approaches to measuring the price that you would use to deflate. And so John's is kind of the cost per successful outcome, that sort of middle line, and the top one is unadjusted. So John basically said, look, unadjusted prices aren't increasing, but adjusted prices are going down, productivity is higher. If you think about the welfare approach, you actually get much larger price declines and much more value from the health system. All right? So if we're thinking about, is the health system producing value? We're spending a lot more. Are we getting value for it? I think the answer is, for the things that we've looked at, not everything has been done, but for the kinds of conditions that have been looked at, and you're sort of using value based on, mortality or quality of life, the answer is yes, we've been getting value for it, okay? Okay, so the question is what the implications of that are. So if we started, the productivity growth is less than the economy-wide productivity growth, then you have a problem, okay? Either Medicare beneficiaries will have less access, or there'll be more cost shifting, and so there'll be pressure on the system, right? But if the productivity growth is higher than the economy-wide multi-factor productivity, then the updates will actually be sufficient to finance constant or even a growing quality of care, right? I mean, if productivity is growing quite rapidly, then it's possible that we'll still have productivity growth and still have improvements in quality even with the Medicare payment updates, okay? But that question is whether or not that's enough. And I think we'll talk a lot more about that in this panel, which is the sustainability isn't just about whether or not the system can produce a constant quality of care, right? Because we actually live in a system where we have Medicare and we have other payers, right? And so if the other payers are saying, I don't want a constant level of quality care, healthcare is really, really valuable, and people are willing to spend a lot of money to get those marginal improvements, and therefore they're paying a lot, then you have this growing divide between what Medicare will pay and what the private payment will pay. So one question you might ask is, well, if we're getting all this value on it, what should Medicare be doing? That's a little bit of a separate question. But so if you think about this sort of growing wedge between what private payers will pay and what Medicare will pay, then you wonder what happens, right? So I think we'll talk a lot about it, but one thing is it may be that Medicare is able to free ride on private. The privates pay a lot. The hospitals say I can invest in new machinery and new procedures. Everybody gets it, so Medicare can free ride. Question is, how long can that go on for? Maybe beneficiaries' access Medicare will be limited. It's like, oh, the private payer pays so much more, so I don't want to see a Medicare patient. I'd rather see a private patient. Or maybe, because we're all worried about what we're going to do about sort of health spending that keeps growing and growing over time, at some point these things may not be worth it, and private payers may actually follow Medicare's lead, and it might be easier for them to actually cut back. If Medicare's not paying a lot, then that gives private payers more negotiation power with hospitals, and so you might see it going from Medicare to the private sector. Okay, so I'm out of time, but let me just quickly conclude, which is I think it's pretty clear that the productivity mismeasurement in healthcare is large, that productivity growth in healthcare is much larger than in the official measurements, especially when you're thinking about it, what are we getting for it? Is real GDP in terms of what people value growing because of healthcare? I think the answer is quite clear. I think that doesn't answer the question of sustainability, though. And so that's it's part of the question, but it's not the full question. And sort of this complex interplay between Medicare and other payers, just makes this question really hard to analyze. Thank you.
Great. Good morning. Let's see. We don't have these all in the same slide here. I think that's me. Oh, good. And slideshow. Oh, great. Okay. Good morning, everyone. Paul, thank you for inviting me to join this group. This is a fascinating topic, hugely important. I only have 2 slides, so I'm going to try to keep it simple. And I think I want to take a step back from the talk about different data sources and different risk adjusters and get at the core challenge that I see in measuring hospital productivity. And the challenge comes from the fact that we're used to thinking about industries and economics and markets in the following way, that there is human capital, physical capital, and technology that determines the cost of production. Picture the Tesla factory floor where you have welders and you have robots and you have the assembly line, and Tesla is trying to keep its production costs as low as possible. Tesla then markets their cars. They put a sticker price on the car, and then you have consumers out there who are shopping for cars. They go on the lot. They can see how compare the Tesla with the other models. There are competitive pressures that are pushing on Tesla and all the other automakers to offer a competitive price to minimize their production costs. And then as economists, you come and count the number of automobiles sold, and you can adjust for quality. And it makes sense to assume that manufacturers are pushing costs down as far as they can and using technology to crank up productivity over time. Okay, now we come to the hospital industry. All bets are off in the hospital industry. That's my big take on it. Why? Because you don't have cost minimizing firms selling in a competitive market. What you have is public policy decisions are setting prices, and then based on the prices that hospitals get, that determines their production costs. That determines how much they spend to produce their services, and it also determines what kind of technology they use. And so everything runs backwards in the hospital sector. That's my big take. And the way to boil it down is that hospitals, how much it costs a hospital to produce a service is determined by how much we choose to pay them to produce that service. So when you're trying to measure productivity in the hospital sector, it doesn't make sense to start with this assumption that hospitals are pushing production costs down and minimizing their operating costs, applying technology to be as efficient as they can. That assumption's just out the window for hospitals. It makes it challenging then to try to track productivity in the hospital sector. And what's really challenging is to think about what's possible in the future. Because if we've been paying hospitals in an increasingly generous way over time, and it looks like they've been getting less and less productive over time, does that mean we're locked into negative productivity growth in the hospital sector? In my mind, no, because if public policy turns around and starts clamping down on payment rates and paying hospitals less, then it's possible that they may become more efficient as a result, and productivity growth may bump up. So that to me is the really big picture challenge in measuring hospital productivity. But the other big point I want to make is that measuring prices and quantities, there are a lot of technical intricacies in how you measure prices and quantities. But I think it's important to try to avoid the lure of the new, fancy, conceptually pure price measure in healthcare. And what do I mean by that? We're measuring prices and quantities for a reason. And the reason is to inform public policy and to look at our hospital industry and to make some judgments about whether we're setting prices in the right way or not, whether we're paying them more than we have to or not. Prices and quantities are also used for other things like COLA and so on. But I think the big picture question that we're trying to answer is, are we paying hospitals more and more over time and getting the same? Or are we getting more and more good stuff from hospitals over time? And is it fair for them to be paid more? So what's challenging in measuring prices and quantities in the hospital sector is we need to keep the motivating question in mind. What's the motivating question in measuring prices and quantities? And the motivating question is, are the prices that we're paying fair? Now, when you're looking at Teslas, okay, we don't worry about whether $35,000 is fair. If Tesla overprices their cars, they won't sell them, and honestly, I don't really care. So people will buy other cars, and the world is fine. In the hospital sector, we're more or less setting prices, and the question is, are those prices fair? Okay, and the concept of fairness is like throwing a skunk in the economist party. Like economists just want to talk about disease based cost measures and risk adjustment and so on. But in my mind, the key question is, are hospital prices fair? Are we paying hospitals too much? Or are we paying them too little? Because remember, we're basically setting prices for hospital care. We're doing it directly in Medicare, semi-directly in Medicaid, and indirectly through benign neglect in the commercial sector, I'd say. But we're setting healthcare prices and hospital prices. are those prices fair? So my concern about the productivity approach that John has taken and David Cutler has taken and Allison Rosen, my concern with that is that it's setting up a situation where you say, yes, we're spending more and more and more on hospital services over time, but hospitals deserve it. They're earning it. They're doing these great things to earn it because the quantity of the positive things we want is increasing over time. I don't think that's really getting at the question of whether prices are fair in the hospital sector, for two reasons. One is mortality may be declining over time. That may have little or nothing to do with hospitals are doing. You may be kind of inadvertently giving hospitals credit for people surviving longer. That may just be education, nutrition. Maybe the opioid epidemic is waning, and we may be inadvertently giving hospitals credit for all the incredibly complex things that feed into health outcomes. That's one concern. But the other concern is that I want to think about whether healthcare prices are fair, thinking about taxpayers, employers who are buying health insurance, and the employees who are producing healthcare. And that kind of price and quantity measurement is most direct if you're using a very simple service price index. The service price index says Medicare is paying $15,000 for DRG 470, which is a knee replacement. Commercial plans are paying $30,000 for DRG 470, and here's how many nurses and physicians and custodial staff and administrators the hospital has to use to produce DRG 470. If we have a very simple service price index, it's totally backward-looking from an economist's point of view, but it's a very simple, direct way to say, are these prices fair? And that's the question in the healthcare space, and it's a different question than I think economists typically set themselves up to answer. And I hope that that lands in an interesting place, and I'm interested to hear where we all take it.
Any reactions to reactors?
Sure.
Yeah, it's on.
Flashing. Hello? Thank you.
Thanks for those perspectives. They're very interesting. I'll start with Louise. So I didn't mean to say that we disagree, or maybe I should say that I disagree that we disagree. I mean, I think we're mostly on the same page, particularly the last slide you put up. So in my mind, what the productivity is telling you is in a payment adequacy context, you know, if the payment update doesn't keep rise with inflation, can hospitals stand still? Can they treat the same patients with the same outcomes or not? That doesn't mean that they couldn't necessarily do better, right? So if there is productivity, so I guess what I'm saying is where the productivity, they don't necessarily have to stand still, right? They can channel it into improved quality. I think that was your point. Paul's made that point. And that may generate additional value. You could see flat productivity growth, but nevertheless improve social welfare. So I think that's also an important question, but sort of the next question from the first question in my mind. With respect to Chapin, a couple of things. I mean, I do think that you're right that healthcare and in particular hospitals are different. There are public hospitals. There's lots of not-for-profits who may behave differently. I do think, you know, your point about beating down on payment rates leading to cost reductions, I mean, that does suggest that cost minimization is at least to a degree on their mind. I will say in terms of our work, what we are measuring is in a sense the gap between what's produced, the quantity and the quality of the care, and the cost used to deliver it. So that's what I'm calling productivity. And so if you have inflated costs because you're kind of you know, a little bit too complacent, that's going to be in the cost measure. So I think that addresses that one point. I think it's very interesting the interaction of the different sectors, right? So growing out of the IOM work, we actually had looked and saw that in areas with high commercial reimbursement, you saw lower Medicare spending and utilization. And so that, you know, there's this idea that, well, maybe if you cut Medicare prices or reimbursements, you'll just charge commercial insurers more, that's the cost shifting view, and economists tend to be skeptical of it for reasons we could discuss. But what I'm talking about actually is it could be on the utilization side, because providers have they just know a lot more than we mere mortals do and have an informational advantage over us, and could deliver care that may be lucrative to them in response to right. So if they're doing well on the commercial side, maybe they feel okay dialing back on the Medicare side. And then my final comment, I hope I haven't taken too much time, is this is for Chapin again. I would just love to, please take this in the right spirit. I would just love to know how you would define fair in terms of what the right prices would be.
Okay, thanks. Yours is okay. Any thoughts, Chapin or Louise?
Oh, I have questions for Chapin too. So I think one of the things that was interesting is you start off with this idea that prices lead to technology. And then you said, but we should make prices fair. And then what I'm saying is you really want to know what the technology so if you spend more, if there's more technology and we're getting a lot for it, then you might want to do that.
You have to use the mic.
Sorry.
You don't have
So I think it's true that technology is endogenous to prices, but then it's not just fairness you want to ask about. You really want to say, how much should we be spending on health and how much should we be spending on everything else? And when you think about taxpayers, it's the same question, right? So you don't really have the ability to pick and choose, well, I'll take this from Medicare and I'll top it off over here. And so the choices that Medicare makes are actually choices for how much care people will get. And so I just think that I don't think you can ignore the question of, are we getting value for this care? And that's got to have a public policy implication.
Yeah, well, the question of what fair. So I just put out a study a month or so ago looking at commercial prices for hospital care relative to Medicare. And when I think about fair, I don't know what the right fair price is, but what I think about is Fort Wayne, Indiana, is the poster child for high commercial hospital prices. And what you have in Fort Wayne, Indiana is the school district is paying probably $40,000 for a knee replacement. Medicare is paying maybe $15,000 for a knee replacement. There's a nonprofit system that dominates Fort Wayne, Indiana, and they're very aggressive on their pricing. And most of the commercial revenues that hospital gets in Fort Wayne, Indiana is profits. Most of it's profits. So the fair question, there's no obvious way to come at it, but I think the school district is being squeezed. Their wages are being squeezed, and I think the hospital in Fort Wayne, Indiana, is being over-reimbursed. And now they're an outlier, so it's fairly clear that they're off base. But I think the general question applies, and the fairness question is getting at employees who are paying for employer-sponsored insurance through foregone wages, taxpayers who are paying for Medicare, people paying their premiums and their cost sharing. All of those folks are on the buy side. On the sell side, it's nurses, custodial staff, administrators, executives, and there's a fairness question here. And what I worry about is if we measure quantity as successful stays without a readmission, and readmissions drop, does the hospital get to keep the money for the readmissions that didn't happen? I don't think it's fair for the hospital to get to keep the money. I think we want to push hospitals to reduce readmissions, but we want the savings to go back to the employees and taxpayers and premium payers. That's where we want the savings to go. So I don't know if that resonates.
Thank you. And I was going to go to the audience for questions. Stuart? Yeah, just wait a second till a mic comes to you.
Help me out a little bit, because everyone was great. So Chapin, those your two movements in the private sector and healthcare in general, what about the producers? So if I'm Tesla and I think, oh, I'm going to be able to sell my car for $250,000. Based on that, I create a car with all the tool, with the fancy stuff like that, and I play it out, and then I come to the end of the marketplace, as you pointed out, and the marketplace says, you can't sell it for $250,000. Now, I already made this decision. So what I'm curious about, and I'm particularly curious when we get to healthcare, is the loop. So now the marketplace says, hey, you can't do that. Going forward, you have to do something differently. So the marketplace then sends it back to the producer, and they have to then come up with a different kind of a car, or they're going to go out of business. So we need to look at the producer. Now, I'm particularly concerned about healthcare because, so I'm a producer. Increasingly, the producers are in monopolistic or oligopolistic situations where we've had massive amount of consolidation. So they're sitting there. I hate to say this because I'm giving my speech, I can go home. Medicare is becoming irrelevant as long as you got a private sector, thanks to the research that you've done, that basically is saying to the hospital, whatever you charge, we'll pay, up to now. And therefore, I'm a producer, I'm a hospital, I'm going to produce what I want, and I'm going to pay myself, I'm going to have, I don't think they're making profits in the classic sense. They are higher salaries, they have more people, they have fancier buildings, whatever you want to say. But what I'm concerned about in your models is the producers and how they really look. And I don't think it goes this way. And it surely doesn't go from public policy to the producers. I think the producers have ignored public policy in the last couple of years. And if public policy is Medicare and Medicaid are increasingly irrelevant because of the ability to sort of generate. So how does this loop work in your models? I mean, everyone said sounded right, but I had problems with the looping and focusing on the producers.
Yeah, actually, if I could follow this up, Chapin did some very important research on cost shifting when we were colleagues at the Center for Studying Health System Change, with the implication kind of lining up with MedPAC's research that if Medicare squeezed payments, hospitals didn't shift them in the aggregates, but they cut their costs. And I was wondering, the hospital industry is so much more consolidated now. What your thinking is, Chapin, about what's happened since the data that underpinned your research was done?
That's a good question. We should update the study. But on the question of let's see, is public policy determining prices? Clearly, yes, in Medicare. Clearly, yes, in Medicare Advantage. Indirectly, in Medicaid. On the commercial side, I'd say we're actively maintaining a public policy that emboldens hospitals to consolidate and to set bill charges at astronomical levels to punish any health plan that dares cut them out of their network. That's a public policy choice, and it's not directly setting rates, but it's benign neglect, and it's having a clear outcome on negotiated rates. We're choosing not to apply policy options that would rein in those prices, except in very nibbling around the edges ways like surprise billing.
Yes, so I think one of the things that kept on coming up is this an antitrust issue that we're worried about, or is it sort of related to Medicare in some sense? And I think the question, which is more like, what are the implications for Medicare of this consolidation that I think are unclear, because, and it does depend on that loop, right? Which is maybe some of it goes to higher wages and fancier buildings, but maybe it also goes into more investment in your new technology that you can now afford, which then will have spillover effects, probably positive, I think, on Medicare. And so it's but I don't, I think you're right that, well, we don't necessarily have a great model of hospital behavior, which is, I think, what you're talking about. And, what comes up with, like, if you squeeze them, do they get more efficient? Well, why is that? But I do think that you have to think about that investment in technology aspect of it that, might not show up right away, but will show up over time as, I think, some of these productivity improvements that John's measuring.
Right. So if you, well, two things. On the $250,000 Tesla, so Tesla rolls out their car for $250,000, nobody buys it, they cancel the production line, they offer a different car, they go out of business. There are competitive market pressures that are disciplining Tesla in its product offerings. In the hospital industry, you have the hospital in Fort Wayne, Indiana, charging $40,000 for a knee replacement, and the market discipline mechanism is just completely paralyzed, and employers are terrified of switching the health plans. The carriers have these long-term symbiotic relationships with the hospitals, and the hospital is raking in these huge revenues and then distributing a lot of the profits to physicians through their own physician practices. The market mechanism is paralyzed, and the feedback from the ultimate buyers to the producers is going to happen through public policy mechanisms rather than conventional market forces.
Yeah, and actually one more thing is the heavy degree of subsidies to the Fort Wayne employers makes them less likely to take significant action that their employees may not like to control what they pay, the tax exclusion.
Yes.
Thank you. Other questions? Okay, sure.
Just real quick. So I'm this Fort Wayne example, clearly we have a complex and highly varied economic environments, and that leads to some weird stuff. I'm sympathetic to that. Sort of at a more macro level, you can look across economic sectors and ask sort of what's the relationship between the return and the risk, the investment risk for that return. There's a professor at NYU, and I'm blanking on his name, but he's done this. And so, at one end you have pharma, high risk, high return. At the other end you have, traditional utilities. And I will tell you that the hospital industry lies right on the sort of central tendency line. And so Fort Wayne, if we looked at Fort Wayne, might be way up here, but sort of on average, they're not sticking out in some way.
Stuart? Stu got him in there? Coming back.
Okay, there.
I thank you for all
Stu,
of these
could you
presentations.
introduce yourself?
Oh, well, I'm Stu Gutterman, and former MedPAC deputy director, and at the Commonwealth Fund when we funded some of John's initial work. Thank you, all three of you, for great comments. We've clearly come a long way in making progress discussing hospital productivity and the implications. I'm particularly, I was struck by all of your comments, but I would, and particularly Chapin's, kind of turning the flow backwards for the hospital industry, because I think that's the way it goes, except I don't think it's linear. I think it's a loop. And so perhaps instead of, the debate over the term cost shifting is kind of dead, but maybe we should have been calling it revenue shifting all along, because of the relationship between the revenue available from the private sector and what it does to costs of hospitals. And so I would make one point about that, and that is we tend to focus on the concentration in the hospital industry, but there's a lot of concentration in the private insurance industry as well, and that insulates insurance companies from the pressure to negotiate harder on their prices. They tend to point at hospitals and say, well, it's all because hospitals are concentrated. But there's really very little incentive for private insurance companies to minimize the amount that they pay for the services that they pay for, because they basically, and the ACA kind of formalize that. They're basically limited to a certain percentage profit on their costs. So if their costs go up, their actual nominal profits go up as well. So there's really a lot of attention we can pay to both concentration in the hospital market and also concentration on the payer market to try to drive down prices to whatever fair means.
Can I comment on that? So I think one of the things that's interesting about all this discussion and bringing it back to the productivity growth is somehow sort of these stories to say, oh, they're just getting all this money and they're kind of wasting it. And yet when you do the question, when you look at the data and saying, are we getting value for on average? Now, that doesn't mean you couldn't do much, much better. But we're saying they're getting all this money and they're sort of, what they're spending it on seems to be worth it on average. Doesn't mean you couldn't do better, and so I think that's an important component to the discussion. It brings it back to John's stuff.
Jeff?
Yeah, Jeff Stensland, MedPAC. I would just like to hear your thoughts on who should get the benefit from the productivity enhancement. I think in real dollars, I probably pay less for a computer now than I did 30 years ago. And Apple gets a little bit of that productivity benefit, but I get the vast majority of it. And if you kind of look at European countries and their life expectancy changes and their wages for the last 50 years, it looks like compared us to them, the consumers got a little bit more of the productivity benefit there. The producers got a little bit more of the productivity benefit here. How do we look about who should be getting that productivity benefit?
In the automobile market, the consumer gets most of it, right? And I think in the healthcare world, if we can figure out how to push hospitals to produce the same outcomes at a lower cost, hospitals shouldn't get to keep most or all of that. That should come back to taxpayers and people paying the premiums and people paying the cost sharing and so on. So Jeff, I think you set up a question, but you answered it beautifully.
Although presumably, you said that consumers should get it.
Yes.
The question is, what has to happen for that to occur?
Right.
I mean, one other quick point is your point it sort of adverts to it's been a while since I've done regulatory economics, but in utilities, in rate setting, right, there's this view that we should claw back any gains that producer or the utilities make, but what then is the incentive for them to go ahead, right? So you could set, maybe like a 5-year kind of cap. They get some return on it, and then you go ahead and claw back, something like that.
Other questions? Yes.
Good morning. Jennifer Friedman. I'm with Stryker, the medical device company, but I was with Ways and Means when we were doing health reforms, so I am scared to confess that I take some responsibility for the productivity adjustment, so apologies to you all. I had a question for Louise, because near the end of your slides, you had there, is Medicare free riding on private payer, which then I had to check your bio and check that you were an economist, because that struck me as cost shifting, kind of. And so I just wanted to parse that a little bit and see sort of how that, everything I've ever learned from Jim and from Mark Miller and all the economists about no cost shifting when I was on the Hill, I just wanted to sort of flesh that a little bit more and sort of how that fit in with sort of what we always hear from all the economists about that.
So I think that's why Paul said maybe we should have a new name for it. So cost shifting is Medicare cuts its payments and therefore private payment rates go up because somehow the hospitals are not profit maximizing and they just need to cover all their costs and they're able to. They could have had higher private rates before, but they chose not to. But now that Medicare's cut their rates, they're going to go up. That's not what I'm talking about. What I'm talking about is if you think about the production process where you have fixed costs and you have marginal costs, you can imagine that if it's worth it to buy some huge new technology and you can afford it because the private payers are paying you for it, that at the margin, it may well be worth it for you to use it on Medicare, or there may be norms that say even if it's not, you don't have different levels of care for different people. And so it's free riding in that sense. It's not cost shifting, but it just says, if there's a lot of money in the system and Medicare is setting prices, the Medicare may be getting benefits that are rising faster than they would get if the private payers set the same prices as Medicare. Did you?
Yeah, just so another term for it might be cross-subsidization. So if we move away from even the payer discussion, within a general hospital, we want them to be providing a range of services, right? Not all of those services are equally lucrative, right? Cardiac care is a lot more financially appealing to hospitals than is mental health. And yet we want most hospitals to be capable of providing some mental health services to their communities. So it's the same kind of thing.
Actually, when I teach health economics, I use the term price discrimination. Charging different payers different amounts, which is distinctly not cost shifting. Yes, the woman on the aisle there.
Hi, Marion Grant from the Coalition to Transform Advanced Care. A question. So we've been talking about hospitals and equating health results to hospitals, but we're trying to shift healthcare to the community. And even some of the operations you're talking about can now be done as outpatient. So I know the topic is hospital productivity, but how is that going to shift if care moves into the community? And then to the question about Medicare not being a big factor because there are commercial payers who are willing to pay in Fort Wayne, with the aging population, is that, that dimension going to change?
Yeah, I'm not sure about how to think about this. So I think there has been this, since 30 years, this shift away from the hospitals. One of the reasons, actually, that Medicare is doing fine is there's all this excess capacity in hospitals, and so it's not so hard. So that you're less likely to have access problems as a beneficiary. In terms of productivity, so I think that there's sort of two things, which is, again, it's quite possible that we could be a lot more productive than we are, and our productivity hasn't been that bad. Those are actually not at odds, right? And so, especially with an aging population and fiscal pressures, clearly whenever the system is not as efficient as it could be, that's wasteful and leaving money on the table. But as these budgetary pressures get higher and there's aging, that's just going to be more and more compelling. So looking for ways of shifting care to the community, I think, is really important. And I'm not an expert on how that happens and sort of the payment rates that you have to make sure that there's incentives to do that. Some of these sort of some of the bundles are really about that, which is like, I'm going to pay you regardless of where the care is, and therefore you have the incentive to provide care in the best way. I'm gonna go back to something that Chapin said and other people sort of have mentioned, which is this idea of not being able to attribute the productivity growth to the hospital is sort of a technical question of whether or not we're doing the measurement right. Because the idea behind it is not to say, oh, life expectancy's gone up, hospital spending's gone up, but the life expectancy's been worth it, so we're done. What you really want to do in these studies is to say, for what conditions can I reasonably say that the changes in outcomes are because of what the hospital did, right? So that might be hard, but at least in a framework kind of way, that's not, that's what we need to be doing, right? We don't want to be paying for hospitals for things they haven't done. I don't know how much that answers your question, but.
Thanks. Well, I think this is a good time to transition to the next panel. I want to thank the panelists for a great job they did. And we'll switch seats.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.